Hi everyone, this is Muhammad and today we are going to speak about cardiovascular embryology. In this part we are going to speak on heart morphogenesis. So first of all what happens is that there is a tube. This tube is going to loop and twist. And this looping and twisting will make this kind of shape like here. This kind of shape what would be the result from looping and twisting. So that's all what first aid mentions. The only important thing that you need to know in this part is that if there is any defect in left right dynein or only dynein, this can lead to Cartegner syndrome or primary ciliary dyskinesia. So what is this disease? First of all, this is the only important part in this paragraph. Like you don't need to focus on cardiac looping or twisting or anything. Just need to know what is Cartegner syndrome or what is primarily ciliary dyskinesia. So first of all, it's a defect in dynein, and this disease is known by a triad of recurrent respiratory infections, situs inversus, and infertility. We will speak about recurrent respiratory infection. What is recurrent respiratory infections? It's an immotile cilia in the lung and sinus. So the cilia function in lung and sinus is to remove or clear the mucus and foreign particles. So if the cilia cannot move and remove the mucus and foreign particles, this will lead to chronic infection, chronic respiratory infection, and it will cause chronic sinusitis, bronchitis, and pneumonia. The second symptom, which is the hallmark of this disease, and this is how we differentiate between this disease and cystic fibrosis, is the situs inversus, which can be either totally or partially. Partially means only heart, like heart will be in the right side as we can see in this image, or it will be totally. It can affect abdomen and chest. Also, infertility. Why infertility? In men, because it will cause an immotile sperm. So if we do a sperm analysis, we will find that the sperm number and count and everything is okay, but the sperms are immotile. And in women, because the cilia in the fallopian tube, which pushes the ovum from the uh, from the ovary to the uterus, is not working anymore. Also, patients with primarily ciliary dyskinesia also come to the clinic with hearing loss. Why? Because of chronic ear infections. The same the same idea in recurrent respiratory infections. The only test that we can do here is the nasal nitric oxide, which is clearly decreased in this disease. And we use it as a screening test, not a diagnosing. And as I mentioned before, we should differentiate Cartegner syndrome from cystic fibrosis. And how we do this, first of all, we have a hallmark for Cartegner syndrome, which is situs inversus, and this photo is very famous, dextrocardia. Also, in cystic fibrosis, patient has abnormal CFTR gene test and sweet chloride test, and also other symptoms for cystic fibrosis. This is an MCQ question. You can stop the video, read it, and try to know what are the keywords. So the keywords in this question is that this 6-year-old boy always have some kind of recurrent chronic infection. Like this is the fourth time this year that he came to the office with this kind of recurrent respiratory infection. And also in the radiograph, there is a dextrocardia, which is a hallmark of our Cartigner syndrome disease. So it's very clear that this question is Cartigner syndrome. Now we are going to speak about the septation of the chambers. So septation of the chambers are divided into, like, chambers of the heart are either atria or ventricle. So first we will speak about the atrium. So what happens is that first of all, septum primum grows like this, like in the photo. So what we can see is that there are septum primum and um, there are ostium primum. Okay, so there are septum primum and there are ostium primum. This is what I mean by ostium primum, this hole. And then what will happen is that the septum primum will have another hole here. Oops. Sorry. So this septum primum will have another hole here. So it will be septum primum, like all of this. And we will have here ostium secundum and here ostium primum. So we have septum primum, ostium secundum, ostium primum. And then from it will complete, like ostium primum will be closed and septum primum will continue to grow until it goes to the endocardial cushions. But we still have a hole here. So septum secundum will grow from here like this until it closes this hole, which is ostium secundum. It will close it. Okay? So in some kind of diseases, there are patent foramen ovale. Patent foramen ovale is when septum secundum can't close the ostium secundum. So there is a hole here. This hole will allow the blood to move from the left atrium here, like this is left, sorry, and this is right. So this hole will allow the blood to move from the right atrium to the left atrium. It will be like this, which is not okay, because if there is an emboli coming from the lower, from like the systemic circulation, it will go through right atrium and it can pass through this foramen ovale, and then it can go to the left circulation. And in this we call it paradoxical emboli. So what is paradoxical emboli? It's an emboli that go in a way which is naturally its way. Like the normal emboli will come through right atrium to the right ventricle to the lung, and it will be pulmonary embolism. And that's how pulmonary embolism is formed. It will be come from right atrium, if it's normal, to the right ventricle to the lung. But if it's paradoxical, then there is a foramen ovale, which will allow the employee to pass from its circulation to another systemic circulation. Anyway, so that's how the septation of the atria happens. That's how septal atrial septum is formed. Also, the most important thing you should know here is the atrial septal defect or patent foramen ovale. That's what you should really focus on. That's what, like, if he goes in a question and he say that there is a guy has like DIC in his leg, and there is an employee who got into like his head, how this happens. So we can say that there is a patent foramen ovale. So the employee came from like his systemic circulation to the right atrium, and from the right atrium it passes through the foramen ovale, and from the foramen ovale through the from the foramen ovale goes to the left atrium, from the left atrium to the left ventricle, from the left ventricle to the aorta, and from the aorta to the aortic arch, and the aortic arch will send this emboli to the brain. That's how he asks about this point. Now we will speak about ventricles, how ventricles is formed. Its ventricles is formed by two ways, like two things, like two septums also. First, the muscular interventricular septum will grow from the apex of the heart. That's the heart apex is like the base of the heart. So the muscular interventricular septum will grow from here, and the aorticopulmonary septum will grow from here, like this. And then they will meet at the endocardial cushion, and that's how the ventricular septum is formed very easily and very simply. Now ignore this, and let's speak about the important things, which is VSD, ventricular septal defect. First of all, ventricular septal defect is the most common congenital cardiac anomaly. That's the first thing you should always remember. Happens in the membranous septum. That's second thing. So what's the importance of VSD? So let's say that this is the heart here. Yeah, like this. So this is the heart, this is the right atrium, and this is the pulmonary trunk, this is aorta, this is the pulmonary vein. So if there is a ventricular septal defect here, so we have a higher pressure here because the left ventricle has a very strong muscle. So the higher pressure will force the blood to move from the left to right. So this movement of blood from the left to right will increase the pulmonary trunk pressure. So increase pulmonary pressure. That's first what will happen. Second thing is that this blood is oxygenated, and this blood is not oxygenated. So we will lose some of the oxygenated blood. Third thing, which is not very important. Anyway, third thing is that it may cause Eisenmenger syndrome, which is when a lot of blood move from the left circulation to the right circulation, so the pressure here will increase, which will force the right ventricle to hypertrophic cardiac muscles in the right ventricle. So the pressure here will increase, right? Because it will push the blood back. So due to the increase of the pressure, hypertrophy will happen in the right ventricle, which will force the blood back to the left ventricle. And now this blood has no oxygen, it's deoxygenated. So this will decrease the percentage of oxygen in the systemic circulation. That's Eisenmenger syndrome. So outflow tract formation is not that important actually. You can just ignore it, and you just need to know that if there is any problem in outflow tract formation, so this will lead to either transposition of the great arteries or tetralogy of Fallot or persistent truncus arteriosus. Let's start with persistent truncus arteriosus. So as we as we can see here in this croquet drawing for the heart, that there is an aorta alone and there is a pulmonary trunk alone. And that's not what happens in persistent truncus arteriosus, because before this separation happens, they were one thing. But if there is a problem in the separation, so there will be one thing. So it will be like this. For example, that's what we call truncus arteriosus. Persistent truncus arteriosus is like there is no separation of the aorta from the pulmonary trunk. Also, tetralogy of Fallot. What is tetralogy of Fallot? We can first explain it on this draw because it's easier, and then I will explain it on this one. First of all, tetralogy of Fallot is pulmonary valve stenosis. Like here, there is a stenosis here. This stenosis will cause increased pressure here, and this will lead to right ventricular hypertrophy. So we have pulmonary valve stenosis, we have right ventricular hypertrophy. Also, we will have ventricular septal defect. Ventricular septal defect, like there is a defect here, and there will be an overriding aorta. There will be an overriding aorta. So the aorta will come to here, like this. That's what we call tetralogy of Fallot. As we can see here, stenotic pulmonary valve, thickened right ventricular septal defect, and overriding aorta. Valve development is very easy. Valve development, we have 4 valves. The 2 lower valves like aortic valve and pulmonary valve. Like we have this aortic valve, pulmonary valve. We have also mitral and tricuspid valve. So aortic and pulmonary valve are derived from endocardial cushions of the outflow tract, and mitral and tricuspid are derived from the fused endocardial cushions of the atrioventricular canal. Aortic arch derivatives. So we have the first arch, it's the max. So maxillary, part of maxillary artery. So first maximal, like first is the maximal. Second aortic arch will give us stapedial artery and hyoid artery. So it wanna step high, it's the second. So it want to step high to be the first. And also second starts with S, so it will be S. So first aortic arch will give us the maxillary artery, and second will give us stapedial artery and hyoid artery, which is step high. Third arch will give us common carotid, like C, it's like 3, third, so it has 3 C's. Common carotid and internal carotid artery. And also saying C is the third letter in the alphabet. C is the third letter in the alphabet. So third, C, 3C. Fourth arch will give us aortic arch and subclavian artery. 6 arch will give us proximal part of pulmonary arteries and ductus arteriosus, and because it's the 6, so it's very young, very low, like very small. So it's like baby will say baba or dada, like PPPA, papa or dada, ductus arteriosus or proximal part of pulmonary arteries. Abnormality in 6 arch cause patent ductus arteriosus. Abnormality in 4 arch will cause coarctation of the aorta. There was 2 questions on the 3rd and 6th arch on eWorld, and that's all.